Hey, it's your old pal Dr. Steve, and welcome to the SARS-CoV-2 COVID-19 updated situation report for June 13, 2020. This is the 11th in a weekly series. Previous episodes are available and have general information about the current pandemic, antivirals, vaccines, and basic science that are not covered on a weekly basis. Okay, let's get started with the statistics that we're following this week. Okay, I skipped last week. It just was slow news week when it comes to this virus as far as new treatments and stuff. So the last week's data is missing from this. Right now in the world, we've had 7.645 million cases. And the deaths per 100,000 is around 0.54. The United States has 2 million total cases. These are known cases. There may be other, obviously, unknown cases of asymptomatic individuals. The cases per 100,000 are about 626, and we had 34 to 35 deaths per 100,000 people, which ranks 9th in the world. Brazil has 850,000 total cases, with a death per 100,000 of 20, and Russia falling into third place with 519,000 cases, and very low deaths per 100,000, which is interesting. I'd like to explore in the future why their death per 100,000 level is so low. I'm assuming, again, that this is due to Russia being a very, very large country with a lot of space between their large cities, and that these outbreaks tend to be in urban areas, and then the larger population in the more rural areas really haven't been affected. As far as cumulative death rates, we're looking at the slight emergence of an S-curve for the United States. So these are cumulative death rates. These charts can only go up or flatten. They can never go down because these are cumulative numbers. So you can see the curve for Italy and the United Kingdom, France and Spain are starting to flatten out very nicely. Belgium as well. United States just barely starting to see a bit of an S-curve, just a slight curve to the right, so we'll be watching that over time. This is United States. New daily cases. There does seem to be a trend downward for new daily cases, so we should see hospitalizations and deaths declining at a similar rate but delayed over time. Okay, we've been following the reopening of Georgia, which reopened on May 1st, despite not fully meeting the federal government's criteria for Phase 1 reopening, but they did it anyway, and they did pretty well. You'll note that the 20-day simple moving average is roughly flat, although the more recent data does show that the new cases line, which is the green line, is starting to bump up against that top Bollinger Band. And if you remember from previous COVID SitReps, that when the line starts to bump up against that upper Bollinger Band, that signals an upswing. So we are starting to see some upswing. It's very early, and we'll have to see if this establishes a trend over time. As far as new hospitalizations, Georgia continues to fall, and that's a significant downward trend, which is good. And New York's new cases continue to fall over time. You can see the 20-day simple moving average continues to decline, and the new cases line remains below the simple moving average and is bouncing against that bottom Bollinger Band, again signaling a downtrend. Florida, on the other hand, was doing pretty well, and then, the last few days since June 9th has shown a significant upswing in new cases. New hospitalizations, however, are remaining low, but that should trail by anywhere between 5 to 14 days. So the next 2 weeks will really tell the tale on that. We'll stay focused on Florida. Here's Texas and South Carolina. Only reason I'm putting South Carolina on here is, well, their cases are increasing and the line is above the 20-day simple moving average. But I'm going to South Carolina in 3 weeks, and so I have a personal interest in this. Texas is also showing cases above the simple moving average as well. California has, as far as new daily cases, a consistent increase. However, California is committed to increasing testing, and this may simply be a function of testing. So down the line, the problem with California is on the database that we're using, they're not reporting new hospitalizations, which to me is really more important. The number of cases is interesting, and it details spread and speaks to testing, but it doesn't tell what we're really interested in, is how many people are really getting sick and how many people are dying from it. So we'll be watching that over time. And as this thing continues to mature, we'll be following those numbers preferentially. So I keep hearing about this herd immunity strategy, which is a real strategy. Let people just get sick until enough people have it, and the virus will go away on its own. And here's sort of how herd immunity works. If you look at the top of the naive population, the person in red is infected, and then that person is infecting 4 other people. And those people go on to infect 4 other people. And then you have a population that becomes immune, assuming they survive. Now, if you look at the bottom row, that person in red is trying to infect 4 people, but is only successful in infecting 1 person because the other 3 are immune. And then in the middle, you can see that person is thwarted in his or her attempt to infect other people. So these people are protected. So what is the real R0? Well, R0 is the basic reproductive number in an idealized, totally susceptible population. So in other words, if all things are equal, about how many people would one infected person infect if everyone was totally susceptible to it? And that is the R0. We've talked about that on previous episodes. RT is the real world reproductive number using real life data. So how many cases are actually generated from one person on average using new case data? And you can do this mathematically just looking at new cases and how often they're reported. So when RT is less than 1, the virus will stop spreading. When it equals 1, there will be a linear increase in total cases. In other words, 2,000 people infect 2,000 people, infect 2,000 people. So that is a linear increase with a slope of, if that's every day, with a slope of 2,000. And then when the RT is greater than 1, rapid spread occurs, and you start seeing that curved geometric line when the RT is 2 or greater. Although you will see it, it's just less, it's more subtle. So right now we're looking at, and this is from rt.live, we're looking at Arizona as being the area with the highest RT, followed by Alaska, Vermont, Arkansas, Washington, Utah, and South Carolina. Hawaii looks as if it has the RT of 1, and then New York, actually, because of excellent work by the populace in physical distancing, has the lowest RT right now at 0.8. So we should see cases continuing to decline in New York. New Jersey also doing very well, Connecticut and Michigan following close behind. So let's just look at Arizona. So the critical population that has to be immune to get herd immunity to kick in other words, to get the RT less than 0.9, is described by this formula: 1 minus the quantity 1 divided by the RT. So if we use this graph to show that the RT is right around 1.2 for Arizona, if you look at the right and then look at the far left. Therefore, we would need 1 minus 1 divided by 1.2, when that equals 16.7% immunity to get the RT to 0.9. If we were just going to use just a pure herd immunity approach in the environment that we're in right now, where most people are still physical distancing. So why not just let everybody get infected and see if we can get to that 16.7? Because that seems like a low number, right? Well, the Arizona population is 7.28 million. 16.7% of 7.28 million would be 1.2 million cases. 1.2 million cases. As of today, Arizona's had 34,000 cases and 1,189 deaths. So we are only 2.85% to goal. And if we extrapolate that up to 16.7% of the population, there could be a potential of 41,719 deaths if the current death rate holds up. So this is why we're really looking for a treatment and a vaccine to accomplish this herd immunity, rather than just letting everybody get sick and roll the dice. New CDC guidance, updated June 12th. There are new guidelines for reopening, and the link is below. There's no real need for me to go through it exhaustively, but check it out. And it is up to date and may have something of interest in there. It's mostly common sense. Let's just take a second to talk about convalescent plasma. This is not a new idea. Plasma from recovered patients been used for decades, even 100 years or more, to treat new cases of infectious diseases. And the way this works is antibodies remain in the blood from newly recovered patients. And, there may be other factors as well that help prevent other viral infections, including interferon. It was used in the 1918 influenza pandemic, and it was used in SARS 2003, but it had varying results in others like Ebola, swine flu, and MERS. So there's some ongoing research. Houston Methodist Hospital is the first U.S. institution to study convalescent plasma in critically ill patients with SARS-CoV-2 infections. Preliminary study showed no adverse events. I mean, people are using this stuff, but this is actually a controlled trial. This wasn't an efficacy study, but participants generally improved. They were really just looking at safety. And any time that plasma is donated, it's got to be tested for bloodborne pathogens like the hepatitis B and C, HIV, West Nile virus, Zika, syphilis, and things like that. There have been about 12,000 patients who have received convalescent plasma. We don't have good data on those 12,000. So a lot of times it was used as a last-ditch effort, but it's more likely to be effective early in the disease. But it's only currently approved for serious or life-threatening disease. So the problem, of course, early in the disease, most people are going to get better. So you have a limited supply. You want to use it in people who are really sick, but the ones that are really sick are the ones that probably won't get as much of a beneficial effect from it, although it's most likely still going to help some people. By the time serious life-threatening diseases occurred, that cytokine storm, which we've talked about before, is already in full swing, and often we'll have to use immune suppressants, which would be more likely to be helpful at that point. So convalescent plasma in someone who is severely ill, and then maybe tocilizumab or other drugs that we've discussed in the past might be worthy to give at the same time. So published data is still limited. There was an uncontrolled study of 5 whole patients. Wow, don't go crazy. On standard therapy and mechanical ventilation, their temperatures normalized in 3 days. There were 4 out of 5 did. Their viral loads decreased. All were stable or discharged, but it's only 5 people, so it's a very limited data set. But their length of stay remained long, meaning that these people were really sick in the beginning, up to 55 days in the hospital. And their results were probably affected by timing because all these people were critically ill. So ongoing research, there's 102 studies overall on convalescent plasma at clinicaltrials.gov. Check out clinicaltrials.gov. And these look like some pretty good studies, most of them recruiting, some not recruiting. I didn't find too many that were completed. As a matter of fact, only 1 was completed, and none have been published yet. Now that looks like a good one, efficacy of convalescent plasma therapy in severely sick COVID-19 patients. Let's get the data out there, and then let's start looking at people who are less severely ill. The more that people recover from this illness, the greater the pool of convalescent plasma that's out there. A little bit of drug news. The use of ACE inhibitors and ARBs has been shown not to be a danger. The initial fear was that ACE inhibitors and angiotensin receptor blockers would actually, by blocking angiotensin receptors, would upregulate, the body would upregulate, produce more receptors. And that would put people at greater risk for infection by SARS-CoV-2 because it uses the angiotensin receptor as its target to attach to with that spike protein and then inject RNA into your cells. But there have been several studies now, and there was a May New England Journal study that showed no increased risk, and a UCLA study this week confirmed that. So if you are on one of these and you are worried about this because initially this was a concern, it is no longer a concern. Do not stop these medications. That's actually the worst thing that you could do, is to upregulate your receptors and then stop taking the drug, because now you have more receptors than you did. As long as you're blocking them, you're good. Avifavir and Favipiravir are now approved in Russia. This drug inhibits viral RNA, but not human RNA or DNA synthesis. So it has very few adverse effects, although one animal study showed that it may be teratogenic, in other words, cause birth defects, so it's not going to be approved for use or testing in pregnant women until they could show conclusively that this is not a concern. There are 24 studies on clinicaltrials.gov. None are completed. There are only 4 primary Favipiravir studies that are actively recruiting, but there are several double-blind studies planned. There are commercial studies, and one of them is Glenmark, are already in phase 3, and that data should be reported mid to late July. If this works to prevent people from being hospitalized or prevent people from dying, we can mostly just go back to business as usual while we're waiting for a vaccine to be produced. So, in the meantime, stay healthy, reopen, but be smart. Don't forget physical distancing, hand washing, and cloth face coverings. All these things still matter. Washing your hands like crazy. Don't stick your fingers in your mouth or your nose or your eyes. I think most of us have gotten away from that. And the end of the handshake, I've been advocating that for years, and then it's finally coming to fruition. So there's a silver lining to everything, I guess. Do not lose hope. There is light at the end of the tunnel. Check out our Twitter at Weird Medicine, or our podcast at riotcast.com/weirdmedicine, or at thelaughbutton.com. And on SiriusXM, Faction Talk on demand, Saturday nights at 8 p.m., Sundays at 5 p.m., and particularly on demand. Thanks for watching. We'll see you next week for the Weird Medicine COVID-19 Situation Report. Take care, everyone.